because of course when you think multiple, you're thinking of something like metastases, or perhaps something more syndromic versus something more solitary, which would make you think is this something more neoplasm. Okay, no neoplastic. Location is important. Is this intra or extraaxial? And as you know, your extraaxial signs includes, having some cortical gray matter between the mass and the white matter. You've got a broad dual base, which displaces and expands the subarachnoid space. And you can also have what we call a CSF cleft, which is a thin rim of CSF between the tumor and the brain parenchyma. And of course, with some displacement of the subarachnoid vessels. So things that we already know, but it's just a little bit of a refresher. Compartment-wise, it's best to be as specific as can in your description because that really helps you to narrow differentials. Is it supratentorial, infra, suprasellar, or suprasellar? Okay, so is it posterior fossa, i.e. is it above the tentorium, or is it kind of midline within the sellar region? Is it pineal? And of course, whether it crosses the midline, as we know, lymphoma is one of those that does cross the midline, and also certain gliomas. Okay. Other things you look for, so you've got, that's where all the rest of the sequences helps you. Really your flare sequence, is it the same as CSF intensity? Is it cystic? Is there calcification, like blooming artifact, or hemorrhage on your susceptibility weighted images or grain echo? Is there fat? Is it bright on T1? Is there restricted diffusion, i.e. high on DWI, low on ADC? And of course, is there enhancement? And normally we do a T1 post-contrast, so pre and post-contrast for enhancement. Often in MSK, we do a fat set sequence, but that's not always the case in neuro. Okay. So this is a extra extraaxial mass, what's looking like a lymphoma. Okay. Oh, no, sorry, meningioma. Apologies. Okay. So I have two candidates. Could I have candidate 1? Can you say hello if you're there?
Hello. Okay. Good evening, Doctor. Okay. Yes, I'm ready.
Yes. Would you be a bit louder? I think you're a bit soft on my side.
Okay. Hearing you well. Yes. Well, this is an CT study of.
Yeah. Just once again, I'm going to scroll because this is a slide deck. Okay.
Okay.
So I'm scrolling. Okay, and I'm going back.
Okay. So.
Yeah.
I am provided by CT with a neck, which showing there is well-defined mass in the region of the infraparotid space and the right vascular space or of the right carotid vascular space. I see the mass related to splaying of internal and external carotid artery. However, in major practice, I need to see this in other reconstruction, coronal and sagittal view. The first for me, this is be a paraganglioma carotid body tumor that's splaying internal and external carotid artery. I need to see the full series of the image, and I don't see in the other side another same lesion. It is more common to come 60% or I think 30% bilateral. I need to see also the coronal view to excluding other paraganglioma. This is a highly vascular tumor. Could be done electrotoid scan. It is paraganglioma, and also this don't need to do a biopsy from here. I'll confine my finding to the referring physician and refer the case for the head and the neck surgeon.
Can I ask, so what's your different shows again? So tell me your 3 different shows.
Okay, for the first, this is a carotid body tumor. Second, this glomus vagal. Could be schwannoma and neurofibroma, also enlarged lymphadenopathy.
Okay, so if I give you a bit more information, this is a girl. She is 7 years old. Bit of weight loss, appetite loss, but nothing specific. Does this change?
Yes, I will go with the lymphadenopathy more. I will go with lymphoma. Would be this lymphadenopathy from lymphoma as a result loss in this age.
And would you do any further imaging to confirm what this is? Because you gave me quite a few earlier.
Okay, I think I will go to MRI with contrast.
Okay. All right. So, I mean, the ones that you mentioned, they're often a bit more vascular. So, which is why we didn't think this was it was a glomus tumor or one of those paragangliomas, because they tend, or rather the glomus tumors really, because they tend to be a bit more vascular. So this one seemed quite homogeneous. in the region of head and neck. Okay, so you say it's splaying. I'm not that convinced it's splayed. More that it's there's mesh effect. It's not in between the vessels. Okay, the carotid vessels. So this, and because it's a head and neck region, we see a mass there. Okay, let's see what the diagnosis is. I think so. Looking at it. Sorry, there's a few more images here. So in my head, I would be thinking of course, it's head and neck. Are we thinking of something like what you said, the lymphoma? Of course, the history would be one that that would help us. So this is a swelling that's been there for quite a while, for about 6 to 8 weeks. There's some non-specific symptoms, but all the other differentials are, as you said, is within reason. The only thing here is that I don't think it's as vascular as what I like the others to be, and this is quite homogeneous. And then the other thing I'll be thinking of is the head and neck. Sorry?
I can go to the parotid gland tumor, polymorphic adenoma also.
Sorry? Again?
Parotid space tumor from parotid gland on the right side is solid. So I can add the polymorphic adenoma from parotid gland.
Yeah, that's true. But often those are a little bit more in the adult population than the children's population. Yeah, so which is why, yes, these are all differentials. What I'm trying to say is that in head and neck, all of these are reasonable differentials, but it's really what's more common. And so in this case, the two things that came to our head is this rhabdomyosarcoma, because in pediatrics, this is quite common. The other thing is lymphoma. Not to say that all the others aren't, but it's just that because we are looking at the pediatric population. If you're looking at the adults, then that would be within reason, okay? So this was lymphoma. And I've kind of, this reason because I've only shown you part of the story. I haven't shown you the other parts of the history. I mean, the other form of imaging. So it's just on CT, just showing you it's quite homogeneous. And also because lymphoma is one of the third most common pediatric malignancy. You've got 50% associated with your Epstein-Barr virus. And, in X-ray, we know you're looking at the anterior mediastinal mass, you're thinking of the 4 Ts. But of course, the thymomas and the thyroid cancers are not the ones that are really as commonly seen in pediatrics, not to say that they're not. The other things to think of is a teratoma, okay, but we are of course looking for evidence like it's more anterior mediastinal. This is very more towards the neck side. And of course, if something more anterior mediastinum, then we are looking at in your more classic lymphoma, then you think of diffuse thymic infiltration, but also a big normal thymus can look like that, particularly in the younger population. So something that we do is we can use ultrasound to differentiate whether your thymus is a normal thymus, that's just a bit big, or is this one that's infiltrated. Lymphoma is the same as an adult, the way we use CT to diagnose. So we don't really go to MR unless we think that this is not lymphoma. And I think the reason why we didn't think it was the other differentials that you mentioned is because it's quite homogeneous and we didn't think it was particularly vascular, avid vascularity. You use PET and CT for staging and follow-up, your Ann Arbor classification staging, and of course, complications is airway compression. And in fact, I think one of the studies said 40% of patients with lymphoma, mediastinal lymphoma, actually present with respiratory symptoms. So just a little bit about lymphoma. You've got your classic ones, which is your Hodgkin's lymphoma. Then the other one is the non-Hodgkin's, including Burkitt's lymphoma. I mean, these are the two common ones that we see. As I said earlier, the other thing to think of is a normal thymus, okay, but it's enlarged. The other thing is rhabdomyosarcoma. So whenever I see a kid with a head and neck, two things I think of first, other than a glomus tumor, would be a lymphoma and rhabdomyosarcoma. Okay, I'm not saying that the others can't happen, but I think these are the more common ones to just keep in the back of your head. Okay, so another thing that we tend to look for, so in kids, especially lumps and bumps, we always get them to be ultrasound. So a lot of people say lymphoma can be, you can suspect lymphoma with ultrasound. Notes, how the notes look like. Unfortunately, this is the case. This is true for adults, but in children, this is less likely to be so, okay? Because lymphadenitis or reactive lymph nodes, due to whatever reasons, can look very similar. Some people say peripheral vascularity makes it more suspicious, but I think that's difficult because this case is lymphoma. And the reason why it was suspicious because she had multiple nodal swellings that's persistent more than 6 weeks, although she was very well with no constitutional symptoms. Okay, then there's also the other subset where they are unwell with pruritus due to cytokine release or flood, weight loss, appetite loss, all the features of fever, B symptoms, but yet they have, they have enlarged patellar nodes and also with central vascularity, but of course loss of the normal fatty hilum. So, and this is a child of the on the X-ray of the child with this ultrasound scan. Just looking at the mediastinum just looks a bit more prominent, but then part of it could be the sternum, but this was raised a suspicion, so CT was done, which just showed small but not too enlarged nodes. Okay, so I think this slide here, just for you to note that in adults, if you see a pathological node, that it's more likely to be suspicious of malignancy or something, so a nodal metastases or malignancy. However, if you see in kids, take into account the history. History is very important because lymphadenitis, infected nodes or inflamed nodes can look very similar. And what you need is more clinical follow-up rather than imaging follow-up. Okay. So the other thing I said about lymphoma is that it can also be in the anterior mediastinum. That's one of the more common locations. And sometimes you see on a chest X-ray, an anterior mediastinal mass, especially in a younger child. You don't know if this is a reactive thymus because they were ill and the thymus is just a reactive hyperplasia, or is this because is it within normal limits of thymus, or is this something that's abnormal? So I thought I will show you what a normal thymus looks like on ultrasound. So this is a starry sky appearance. So looking a little bit like the liver, but they call it starry sky. And this is one of the thymus showing that there's a thyroid, inferior of the thyroid, and you've got your cervical part and the mediastinum part of the thymus corresponding to this picture here. Okay. Okay, next case. This is, I'll give you two pictures. So this is the ultrasound. Okay.
Okay, I have provided by...
And that's the MRI. Okay. Ultrasound and MRI.
Okay, can you... In ultrasound, I see there is ill-defined. Okay. So I will comment on MRI.
Okay.
Okay, I have two image of ultrasound which showing there is a large mass, homogeneous hypoechoic mass with showing increased vascularity as a periphery. In MRI, I see there is in this T1 in the right carotid space. I see there is a large lobulated mass splaying the vessels with showing flow void. In T2, there is showing homogeneous high signal with flow wide cerebrovenous vessels, as seen in the coronal, confirmed. In this, I think this is fusion restriction. I see there is showing a high signal in the bottom left. So this are more likely to be a carotid body tumor. And as I said, I don't see any other lesion. The other differential enlarged lymphadenopathy, schwannoma, or fibroma, lymphocyst tumor, for other differential diagnosis for this case.
Okay, would you put any other differentials?
The first, this is for me, it is carotid body. Second, it is schwannoma and no fibroma. Third, it could be glomus legal. The other large lymphadenopathy in this region.
Do you see any do you say lymphadenopathy in this region as well?
However, I don't see any lymphadenopathy enlarged in the level 2 lymphadenopathy submandibular. I don't see no lymphadenopathy seen in this submandibular region. So exclusion for lymphadenopathy will exclude it from my differential.
Okay. And what do you think about this region in front here?
In the front here of this region?
Just sorry, can you see my pointer?
Yes, I see this in the base of the tongue. I think there is in this anterior part. I see there is some high signal, thickening of the mucosa, of the pharyngeal mucosa anteriorly. This could be, but however, this is bilateral seen in both sides. Could be this, to arrange, could be this pharyngeal, in this young age. I will worry about tonsillar hypertrophy. If this adult age enough, I will suspecting nasopharyngeal carcinoma, and this could be metastatic lymphadenopathy from here. However, this one on the other side, or cerebral gland tumor. This one could be cerebral, but I'm expecting this of the patient.
So this patient is 5 years old.
Okay. For 5 years old, I will exclusion the xeroplastic cause. I will go more with lymphoid hyperplasia or inflammatory causes, and this could be, as I said, could be this is lymphadenopathy from this one.
Okay. So this was a rhabdomyosarcoma. As I said, I agree with your differentials given the location, but I think, this is what we've been taught, or I've been taught as a fellow. If we are looking at head and neck tumors, I would accept what you said, your neurofibromas, because I think there's a site where you've got your vagal nerves there. I think I would accept your what you said of lymph. I didn't think you didn't say lymphadenopathy. You said salivary gland tumors. Again, I'm not sure they happen. So, again, they do happen in kids, but it's not one of the common ones that happens in children. You also mentioned stuff like a carotid body tumor, but often they have this salt and pepper appearance, which I'm not seeing here. And what bit I was pointing to you here was that there's a little bit of, this is on the a T2 fat set sequence. I thought there was a little bit of a probably necrotic tumor here. As you can see, this rim. This is on the post-contrast and with your central low signal. So this turned out to be a rhabdomyosarcoma. Okay. It was on ultrasound. We saw this. We were worried. The other thing was, again, I said it was this lymphoma. Okay, like some sort of Burkitt's lymphoma, because they are very common in their head and neck, and so which is why we decided to do in the MRI. MRI, there's nothing specific to say this is definitely rhabdomyosarcoma until the histology, which is what we eventually the tertiary hospital did, and it turned out to be a rhabdomyosarc, but then these were differentials that we put inside. Okay, I would accept your neurofibroma, as I said, your lymphoma. Because of the age, I'm not thinking of something like infantile hemangioma, because the only things that on ultrasound also I would expect to be a bit more vascular, although it's quite well defined. So these, and that could be one of different shows that I've written, but I think the ultrasound characteristics go against it. Okay, but carotid body tumor and glomus tumor, I think that's for an older population than a younger population. All right. So it's actually quite common. In fact, the most common soft tissue sarcoma. Okay, 70% below 12, 40% below 5. Okay, so and up to 40% of them occur in the head and neck. Of course, the associations is you've got other syndromics. You've got a Noonan syndrome, or you've got previous radiation that increases your risk. There are 3 for rhabdomyosarcomas kind of thing, or tumors from primitive mesenchymal stem cells, such as rhabdomyoblasts. You can have 3 different histologic subtypes. You've got your embryonal ones, which is the most common in young children, which is on WAS. You've got the alveolar rhabdomyosarcoma, which is in the 15 to 25 years old, and then the later older ones, which is the pleomorphic ones, which is about 40 to 60 years old. Okay, so ultrasound, you've got a very firm mass with a very variable internal vascularity, but hemangioma is often very, very vascular, like we see from last week. You've got a soft tissue mass can be invasive, but not always. Okay, it can be quite well circumscribed, which we have here, not always associated with bone destruction. Of course, you're thinking of something that's infective, then you're thinking if it's near bone, then you have a lot more inflammatory changes, but this is actually not too bad. And it of course restricts this diffusion because it's quite a solid tumor. So I said earlier, the other things you can think of is lymphoma, infantile hemangioma, and plexiform neurofibroma, but people say if you've got plexiform neurofibroma, you expect to see more sites, so not a single site. And also you can have some target sign to help you differentiate between neurofibroma or schwannoma, but later on, it's actually, you can't really characterize it as well. Okay. So yeah. Okay, so and of course, if you have thinking of neurofibroma, you want to find out if you've got any history of neurofibromatosis. Okay, next case.
Okay. This is an MRI of infant. I see there is a sagittal T2 view. There is mass intermedia here showing homogeneous signal in this below the third ventricle. In T1, it is homogeneous low signal here. In the other axial view in the flare, I see there is high signal in the region of the third ventricle with lobulated border. In the other anterior, I see there is supracellular lesion here with high signal, homogeneous high signal in the flare with heterogeneous anteriorly. So in comparing, there is no evidence of the syphilis. So I'm warning about this mass in the supracellular region anteriorly, and as well as it's going to third ventricle. This one.
Okay.
So the supracellular region mass in center, the first female, it is could be a germ cell tumor. In this region also craniopharyngioma, as well as Lasix graft cyst. However, this is cystic solid lesion. And CCL is normal, so exclusion for pituitary macroadenoma.
Okay, so of the three that you've given me, well done. That's the different shows I have on my list. That's very good. So what do you think is most likely? You said solid cystic tumor, midline, near the region of the cella or supracellar.
Okay, I will go with craniopharyngioma more for me.
Yep, well done. So that's a craniopharyngioma. It's what you mentioned. You've got a cystic component here, which is not really that of CSF density. You can see it's just slightly higher than compared to the CSF, and you've got a solid component that you can see here on the flare, and also with some enhancement on the T1 post-contrast study. Okay, good. So this is a craniopharyngioma. There are two types normally. You've got in the kids one, you've got the adamantomas, so it's mixed cystic solid, and of course you've got another one which is mostly solid. It's adults. It's squamous papillary. Okay, it's a benign, histologically benign tumor, and it rises along over the. I always think of it near the pituitary region, so hypophyseal rectal duct. You do see it. The peak age is 8 to 12 years old, and it's very common. So over 50% of the pediatric supracellular tumors, you can see in that location, almost 60% or 2/3 of it would be. Or craniopharyngioma happens more 60% in about cellular supracellular region, okay, and of which half of it is in the supracellular. And there is a rule that says if you've got on CT 90% cystic, 90% calcified, and 90% enhanced, and it's the wall and the solid components that do. And cystic components are T1 hypertense, as we saw earlier. It's quite different from the CSF. And then you've got variable T2 signal. And I think the best diagnostic tool that I always think about it's a cystic supracellular mass with calcification, which we don't really have here, but there's an enhancing solid component. So you mentioned germ cell tumor or germinoma, which we'll go through later. Not really a pituitary adenoma, just because of the location. And then the other thing is Rethke cleft cyst, and how I think about it is that you don't really have the calcium in Rethke cleft cyst, and often it's more cystic rather than cystic solid components. Okay. Okay, next case.
Okay, I have provided by multiple sets of the MRI. The first one in left, it is flare image axial. It's showing there is mass in the region of the pineal body, which is showing high signal with rim of edema surrounding it, and also there is a transvendimal high signal in the periventricular. Could be this from increased hydrocephalus, increased pressures. And in this one here, I see this. Okay, in the restricted diffusion weighted image, I see the lesion doesn't show restrictions. It's the same low signal. In sagittal T2, I see the region is visually condensed to the region of pineal body. In T2, here, the same. In contrast, showing homogeneous enhancement. So I will be going with the pineal body tumor, pinealoblastoma, as this one. As also differential for me, it is germinoma, as well as germinoma. Okay.
Yeah, so good, well done. Yeah, I've got the same differentials as you, so you can see here that's on T that's flare. You've got this heterogeneous lesion here, and you can see that on the cis sequence, it's your DWI ADC. It's probably very mild degree of restricted diffusion, okay, because slightly high and then low on, there's certain high and low areas on DW and ADC. And on the cis sequence, which allows you to see CSF, there is at the cistern, you can see that there's obliteration of it, and so with resultant prominence of the hydrocephalus of the lateral ventricles, and it's quite heterogeneously enhancing as well on the T1 post-contrast sagittal. So this is a germinoma or germ cell tumor, but perfect in terms of your differential diagnosis. It's very common in the midline, so 80 to 90%, pineal more than suprasellar region, often happens in a young child. And I think if I had shown you the CT, what it shows is that it always engulfs the calcification within the pineal gland, because you can get calcification there. And if it happens in a suprasellar cistern, then your infundibulum looks a bit bulky. Okay. Very variable signal, so about ISO to hyperintense on T1, and variable on T2 as well. And you've got that homogeneous enhancement is slightly heterogeneous with areas of non-enhancement, but the enhancement is quite strong. And because of high cellularity, you also get a degree of restricted diffusion. And with germ cell tumors and a few other of the tumors that we're going to discuss later, you need to image the whole neuroaxis to ensure that there's no CSF spread. And I thought from there, it's good to just revise. This is something that can help you to differentiate between the pineocytoma, pineoblastoma, or germinoma. They often talk about, I can't remember if you remember for your 2As, but they always talk about how it looks like the calcification looks like if you've got a lesion there. So a germinoma, often the calcification is central. Pineocytoma is one is more benign category of pineal tumors, and this is an exploded calcification appearance. You can see in the middle, so it's kind of more circumferential. While pineoblastoma, it's peripheral and quite focal. Okay, but in terms of how it looks quite similar to germinoma, but the location of the calcification, it's the key differentiating factor. Okay, next case.
Okay, I have provided by multiple set of the image. In the first one above, it is T2, showing there is right temporal lobe, cortically based focal space occupying lesion with high signal intensity. In the flare, the lesion showing intermediate signal. There is no significant perilesional edema. In coronal view, I see it is also in the temporal lobe. In the restricted diffusion, I see the lesion showing high signal, doesn't showing restriction here. In contrast, that doesn't take in contrast. So I will going with tumor in this region. I will give ganglioside for this region. I will go for ganglioneuroma, gangliocytoma, as well as exansomatous astrocytoma in this region. It's more common in this temporal lobe. However, I don't see any cystic lesion for exansomatous astrocytoma.
Sorry, so if you just tell me your top differentials again.
Gangliocytoma in this region, and also exansomatous astrocytoma and the Dennett.
Sorry, what's the second one? I think for me, you keep dropping out. So you called DNET, you talk about ganglioglioma, and what was the second one?
exansomatous, polymorphic exansomatous astrocytoma.
Okay. I'm not sure what that one is, to be fair. Okay. Again, I am not, as I say again, I don't know what the second differential is. I have to be quite frank. So this is a DNET, okay. I would go with the differentials for me would be a ganglioglioma. I really don't know what the second differentials that you gave was. What is it again? Can you just read it slowly?
Exansomatous astrocytoma, exansomatous.
Xanthomas. Okay. I always thought those were more, is it? Yeah, okay, astrocytoma, yes. I call it a PZA if I'm not wrong. And that's often one of the ones with cystic tumor with a solid enhancing mural wall is one of the things I think of. So which I don't see here. Okay, so this is a DNET. So it is, I think before I go in there, I think what to take away from here is that if you guys haven't done PEDS before, and I can tell you I'm not a neuroradiologist, often imaging, you can only come up with a list of differentials until they get discussed in a neurology MDT where the radiologists are a bit, they see these tumors day in, day out. They can correlate with other more subspecialist techniques such as MRS spectroscopy. Or even when they take it out histology, then you can say exactly what it is. So for the purpose of the exam, what I want you to go away is not to think, I need to learn all these tumors, but to have the top 3 differentials of, let's say, cortical-based pediatric tumor supratentorial. Okay, because you cannot remember all of these for the exams, and you remember this is just pediatrics. You also have the other specialties to think about. Okay, and pediatric neuroradiologist is a subspecialty. So which is why I've just chosen a key learning points that I want to highlight. Okay, yeah. So anyway, this is a DNET. It is one of the things that they can show you is it causes epilepsy. Okay, I can't pronounce the word today. Epileptogenic. No, I've done it. Epileptogenic, and it's a benign tumor. And often it gives you partial complex seizures, and reason why it's good because it's almost exclusively cortical, okay? And there will be some history of seizures, which makes you narrow down and say, okay, I'm thinking of cortical-based epileptogenic tumors such as DNET. Temporal more than frontal, or just in temporal region. And the other thing to think of is something ganglioglioma can look very similar, okay? But often it's a bit more cystic, mixed cystic solid. So, but coming back to DNETs, you get, it can be hyper intense on T2, like what we see here, quite a large area, or you can have many small cysts, quite bubbly mess, but we're not seeing that pattern here. You can have very variable enhancement, okay, and you don't always have the restricted diffusion, okay, because it's not a very cellular lesion. Good thing is that METs or malignant tumor transformation is very rare. So often they go in, they can take it out. The only thing is that it can come back again. Okay. So for cortical-based supratentorial tumors, which causes seizures, you are thinking of a DNET or a ganglioglioma. Okay. Okay. Case 6. Next one.
Okay, I have provided by multiple sets of image of CT. There is hydrocephalic changes seen as also dilated temporal hole. There is fossa space occupying lesions confined to the region of ventricle with slightly hyperdense, heterogeneous outline, hyperdense compared to the brain parenchyma. So this is a case of medulloblastoma with hydrocephalic change. Need urgent refer for neurosurgeon for shunting or to relieve this hydrocephalus. The region medulloblastoma is also differential for me. It is ependymoma. However, ependymoma usually is showing extension to from magenta from Blashka, and it is more regular outline. It is tooth-based tumor. So this is a medulloblastoma. I will advise to do imaging for access to excluding droplet nets of the spine. Okay, I will refer the case for the brain tumor MRT. This is a medulloblastoma.
Okay, good. So I think we are now coming to a bit more classic things that you see. So this medulloblastoma is classic posterior fossa tumor. Okay, one of the big three, I think. So it's a malignant, highly cellular, so very dense, which is why it's quite hyperdense on CT. Of course, restricted diffusion. So medulloblastoma versus your ependymoma, one arises from the roof, so medulloblastoma, the other arises from the floor. Often you can't tell, but if if anyone here is trying to see the 2As, then that's one thing that they may ask you. The thing here is that if your child is quite young, and if I'm saying below 3 years old, and you've got to think about ATRT, okay, there's no ATRT versus medulloblastoma, you don't really see much of the differentiating imaging features, just that ATRT can be more homogeneous. A bit more medulloblastoma that you may not know. So there are 4 major molecular subgroups. Because this whole neurogenetics about tumor staging as part of improving treatment. So there's the wing or WNT subtype. You've got the sonic hedgehog subtype, group 3 and group 4. Okay, it's not something they'll ask you, but it kind of explains why sometimes the medulloblastoma can look very heterogeneous. Okay. That's because there are different subtypes, and of course a different prognosis from these as well. And like what candidate one rightly said, your differentials is a ependymoma as well, which we'll see a case later. And the other thing to think of is a brainstem glioma, but then that's in the brainstem, and this is clearly not within the brainstem. It's kind of within fourth ventricle. Okay. When you see medulloblastomas, you have to image the entire neuroaxis to look for CSF spread. And interestingly, which I think I mentioned in the last MSK talk, they do have extra neurometastases, okay, in which they look sclerotic on the bone. Okay. So just to show the different subtypes, WNT, sonic hedgehog, group 3 and group 4. Okay. So another example of medulloblastoma, I won't fault you if you said you thought this was ATRT, and this just shows you all the metastases in different parts of the brain. Okay. Okay, next case.
Okay, I have provided by brain MRI in the upper one T2 showing there is mass in the fourth ventricle with irregular border. In the second image showing this mass extension through the extension to the caudal to the fourth, more fourth ventricle with possibility of extension to the foramen of Loschka as well as Magini. In the restriction, the mass doesn't showing high doesn't minimal restriction, mainly over heterogeneous in contrast enhancement. In the sagittal view, I see the extension through the foramen of Magindi. So this is a case of ependymoma.
That's right. So well done. Yeah. So that's the other one in the same region, but as candidate 2 has, candidate 1 has said, it's a lot more plastic. So it goes kind of around through your foramen Magindi into your from the cisterna magna into your cisterna magna, and then the other one is from a Luschka into your CPA angles. Okay, so versus medulloblastoma, it comes from the floor, while the other one comes from the roof. You sometimes can get a bit of fine stipple calcification, but better seen on CT, but we don't have that, so we've got MR. And restriction diffusion really it depends on the grade of the tumor. Okay, similar to medulloblastoma, there are also 3 different subtypes, but we're not going to go into that here because often the subtypes are more talked about in medulloblastoma than in ependymoma. And like ependymoma, like in medulloblastoma, you need to image the whole neuroaxis to make sure there's no to rule out any metastases. Okay, next case.
Okay, I have provided by multiple set of MRI in T2. I see there is bulging of brain stem and bones and the bones. There is a slight hypersignal in the middle. In the other slight high signal, it is likely to nearly to be homogeneous high signal. In failure, this is also showing high signal with foci of low signal in the left side. In restriction, doesn't showing restriction minimal anteriorly. In this sagittal T2, it was a high signal and there was enlargement, expansion of of the brain stem and the bones, and with narrowing of the fourth ventricle. In contrast studies, there is focal, I think there's focal area of enhancement in the left side. It could be this. I think I will going with brainstem glioma, the first for me, glioma in this region.
Yeah,
for this
right. So
I am suggesting it could be this focal necrosis, something like this, or myelinosis, something on top of this pathology.
Yeah. Okay. Yeah. So good. So this is due to the location, and you can see how different it is. This is really centered in the brainstem, very midline, with an area of enhancement and possibly representative of central necrosis as well. So quite heterogeneous signal lesion. And this is a diffuse midline glioma. It's a malignant lesion as well. So WHO grades, the higher the grade, the more malignant, the more dodgy or malignant the lesion. So grade 1's benign. They say you get this classic triad of cranial palsy, lung tract signs, and ataxia. I don't think I've seen one clinically, at least in my in my practice. But I think it's the location that's characteristic. Okay. T1 hyperintense, T2 homogeneous to heterogeneous with variable contrast enhancement, and similar like the other two that you saw earlier, you need to image the whole neuroaxis to detect CSF spread. Things to think about. I put in GBM, but to be fair, a glioma is a glioma. GBM's your classic one you think of as a thick, heterogeneity enhancing central necrosis. It doesn't really look like that. I put in pilocytic estro because we always got to think about that when you are in the posterior fossa, but often they are a bit more cystic with a solid component and not so not so solid as we see here. And the other thing is that if it doesn't quite make sense, you got to think of something like a brainstem encephalitis. So is it an infective cause to this? Okay, so if it's more, so the location of the diffuse midline glioma is quite age dependent. If you're pediatric, you're somewhere in the brainstem or pons, and if you're towards the adults, it can be actually in the thalamus or in the cord as well. Okay. So I hope your screen shows up okay, but this is another case, okay?
Yeah, I have been provided with serial coronal images of a skeletal image of patients showing evidence of a heterogeneous T2 hyperintense lesion within the right lobe of the liver. And the lesion is showing heterogeneous intensity. I couldn't see any areas of necrosis within. This is involving whole of the length of the liver. And the other incidental finding is the pleural effusion noted on the right side. And apart from this, there is minimal perihepatic free fluid and also free fluid in the pelvis. Can I know the age of the patient?
Yeah, patient 2.
2 years old.
Mm-hmm.
Yeah. So can I have other sections like the axial, or these are the only the axial sections images? I think the lesion is seen predominantly involving the kidney rather than the liver. The liver is more displaced anteriorly, and there is minimal free fluid, and also there is some necrotic areas within. The kidney is pushed inferiorly, and there is dilatation of the pelvis. Apart from this, the rest of the liver appears normal. The left kidney shows normal signal intensity, and there is minimal free fluid as seen before. Are there any other sections, any other sequences, or these are the only images covered?
Nope, these are the images that I've given you.
Yeah, I think that I would keep the epicenter of the lesion within the kidney and the suprarenal gland lesion, and my top differential should be a neuroblastoma. The other second differential will be a Wilms tumor, and again Wilms tumor. A third differential, which is very less unlikely to be a large nephrotic lymph node. And I would like to inform my findings to the referring physician. I would like to discuss the case in pediatric oncology MDT. I would like to do any tumor markers for this lesion, and I would like to compare with any previous imaging. And I would like to do CT of the thorax if there are any lung metastasis, and also as I've seen pleural effusion. And I would like to do biopsy of the tumor to know the exact histopathology. Yeah.
Okay. So nice differentials. Okay, and I know I haven't seen you given you all the imaging, but you're right. So this arises from the kidney, so not really suprarenal. I haven't shown you the suprarenal, and this is a Wilms tumor or a nephroblastoma. Okay, so just take note of the spelling of nephroblastoma versus neuroblastoma because it's quite similar. So 80% of Wilms happens in kids below 5 years old. Often you wouldn't think of any associated predisposing syndromes. So things like an overgrowth syndromes, Beckwith Wiedemann. You think of the DICER1 gene, Lee from many. Okay, so it arises from primitive metanephric blastomal tissue, and you have this very large heterogeneous renal mass, which you can also see tumor thrombus, but then we don't have here going into the renal vein IVC. And what's seen here is actually a claw sign, which I'll show you in a different picture. And you can sometimes get calcification in Wilms, but that's more commonly seen in neuroblastoma. And you can have local extension to perirenal fat or tumor rupture. And nice to add that, yes, you do a CT scan because you want to make sure there's no lung metastases at the time of diagnosis. Okay, so very large tumors, it can be very hard to differentiate where it's coming from. And often looking for periphery signs like the claw signs, quite important, and what's doing to the vessels is another thing. But you can see why you need to look at the other imaging as well, because on coronal you can easily think that it comes from the liver when it doesn't. Okay. Yeah, so this is just differentials. Of course, you think of the other things, multilocular cystic renal tumor, but it's not really a cystic looking mass, it's quite solid. Okay. The other thing is that congenital mesoblastic nephroma is often a lot younger, so less than a year, and this is about 2 years old, this child, so not quite there. But yeah, think of one that's under 6 months old. So the younger infants, the neonates rather, it's ones that you think of more the congenital mesoblastic nephroma. And of course, on the other side, when you're someone who's a bit older, near adolescence, you're thinking of RCC. So just another example of Wilms as well, okay, on ultrasound, and then following that, so you get this mixed cystic solid mass. You probably would wonder, where's it coming from here? Is this a claw sign from the renal tissue? And then at the other side, a left kidney and a right kidney looks normal. And you see here nicely this claw sign from the renal parenchyma on these images. And then finally a pictorial just showing you how it looks like. So if it's extrinsic mass, then you get a very blunt, rounded interface with the parenchyma. But then if it's one that it's arising from, then you get very nice, these claw, very thin, sharp angles on either side. Okay. As you can see here, so this claw sign here, and also on this one. Okay. I appreciate it.
Is a biopsy recommended in Wilms tumor?
So I don't think they actually biopsy. I'm not actually sure.
Yeah. Sam, can I step in here?
Go ahead.
So if it's a typical age group, so normally under 5, typical imaging appearances, they don't biopsy any longer. They go straight to chemotherapy. And then they'll do interval imaging to see if there's a response. If there's a classical response, as we'd expect with the chemotherapy, then once it's shrunk enough, they try and do nephron sparing surgery, so they'll go resect it. Once it's shrunk enough, if it's not responding to the chemotherapy, then they may consider biopsy if it has any atypical features or it's an atypical age group.
Okay, thanks.
Toby sees a lot more oncology than we do. So I'm going to, and the floor is open to her, so she will step in if there are questions that I cannot answer. Okay. Okay, next case.
So I've been provided with serial contrast enhanced axial images, CT images of a skeletal image patient showing evidence of a heterogeneously and hyper-enhancing lesion with few calcific foci in the retroperitoneum anterior to the left kidney in the left hypochondriac region. The lesion does not cross the midline. There is no involvement of any vessels. There is no involvement of any extension into the vein. Do you have other sections or?
No, but this is all that you get. And I'll give you a bit
Yeah.
of history. So this is a teenager, about 12 years old, and came in as a blunt abdominal trauma.
I couldn't see any solid organ injury that is seen in any lacerations or contusions within the liver. No, I think the right kidney appears unremarkable. So there is a heterogeneously enhancing lesion located anterior to the left kidney, which is compressing and displacing the left kidney with a few calcific foci. My difference and the lesion is seen separate from the pancreas also, compressing the stomach. My differential diagnosis include here a neuroblastoma because of the calcification. Other differentials might be any solitary stem tumor of the tail of the pancreas. I have been not provided with any other sections and coronal sections. I would like to see other sections. I would inform the findings to the referring clinician, and I would do a pediatric oncology MDT for further characterization and management of the lesion. I would like to compare with a previous imaging if there is any.
Okay, so that's the kidney. What do you think of this appearance here? The parenchyma.
I think that looks like a clause sign, yeah.
So do you think this is still coming from the tail of the pancreas?
Yeah, I would like to. No. I would like to retract the statement that is coming from the pancreas. Mostly suprarenal renal. If it is, can be a Wilms tumor, which is less Wilms tumor, a neuroblastoma. Maybe my top differential diagnosis in this case.
Okay, so I think I mentioned earlier. So if you're thinking of so your congenital mesoloblastic nephroma, you see of it in the younger children, and then if you're kind of between 5 years old, and around less than 5, you're thinking of a Wilms, and then something a bit older, a teenager, you're thinking of a RCC. Okay, so this is a RCC, and it can be associated with other syndromes such as von Hippel-Lindau, tuberous sclerosis, because they get renal cysts, renal abnormalities, AMLs. Of course, any previous renal treatment, you can have an RCC looks like RCC in these age group versus when in adults, so there's nothing much to add to that. And similarly, it can also go into your IVC and have tumor thrombus. Metastases, most commonly to your lungs, bones, lymph nodes, liver, brain. Haven't really seen much of that. But things to think of is so if we go back to the previous picture, that wasn't calcification. I know this is only still image that I'm showing you, but there was actually intratumoral bleed. Okay, secondary trauma, and because your retroperitoneal space is quite big, often these lesions can, it can grow to a considerable size before they are detected. Of course, you'd be wondering, did the patient have any hematuria? Okay, but probably didn't. It was probably microscopic, and you didn't realize about it. I think stincom renal lymphoma, but these tend to be quite bilateral renal mets. You're looking for any other sites of disease to think that where's the primary. Renal oncocytoma, they often say you get a stellate scar, and it doesn't really look like that. And then you think, is this a hematoma? But then that doesn't, the characteristics of enhancement doesn't quite fit with it. And finally, renal abscess. Okay, but then often this is a huge abscess, and you think that patient will be a lot more unwell. Lobar nephronia, often you still keep that contour of the kidney, so it doesn't quite look like that. Okay. Okay, next case.
Yeah.
There are 2 images. So this is the ultrasound, and the next one I'll show you is the MRI. Okay, so I'll show you the next one.
Okay.
Okay, I'll go back to the ultrasound first. And this is a 7-day-old child.
These are the longitudinal and transactional ultrasound images.
Oops, sorry, you're breaking up a bit for me.
Yeah, can you hear me now?
Yeah.
These are the longitudinal and transactional images of a 7-day-old child showing evidence of a ill-defined hypoechoic lesion just in the paravertebral region on the right side. And it is abutting the spine. However, there is no evidence of the erosion of the bone.
Okay, I'm going to show you the
The
MR.
lesion is noted in the retroperitoneum. Yeah, the lesion is noted in the retroperitoneum in the paravertebral region. On the right side, the lesion is displacing the right kidney anteriorly. And apart from, and there is evidence of extension into the spinal canal. There is heterogeneous signal within the spinal canal and also its extension within the spinal canal.
Okay, I also have some XCTs to help you along.
Yeah. Yeah. These are the serial axial contrast and CT sections showing evidence of heterogeneously hypoenhancing region in the paravertebral region, in the retroperitoneum, posterior to the right kidney. And the lesion is showing intraneural extension into the spinal canal. And apart from this, there are no liver metastasis, no focal lesions in the liver. The spleen, there are no lesions in the spleen. So the epicenter of the lesion is in the right paravertebral region, probably involving the right adrenal gland with intraspinal extension. In the 7-day-old, my differentials will be a neuroblastoma, less likely to be a Wilms tumor as the kidney is pushed anteriorly, less likely to be a lymphoma as the age group does not fit of a 7-day-old.
Yep.
And less like, is the patient is having any other symptoms?
He's got a rash.
It's got a rash in the face or
A rash over the body.
sure the body. Other differential can be adrenal hemorrhage, but I don't know, it is less likely because there is intraspinal extension. I'm thinking more in terms of neuroblastoma, and also the lesion is showing loss of fat planes with surrounding the abdominal vessels. So I would like to do a whole body imaging for the patient, like an MIBG scan, to know the extent of the disease. I would like to inform the referring clinician. I would like to do a pediatric oncology MDT for further management of the case, and would like to see any antenatal images as the 7-year-old if the lesion is present antenatally.
Okay, so I've got a nuclear medicine scan as well.
Yeah. I think this is the MIBG scan. I could see the salivary glands and the heart, uptake in the heart and bilateral lungs. Yeah, there is a MIBG avid lesion in the right paravertebral region, keeping in favor of a neuroblastoma. However, there are no other distant metastasis in this scan actually. Yeah.
Good. So this is a neuroblastoma. I don't think there was any metastases on the MIBG. Toby can, I think it's the case from Toby, so she can correct me if I'm wrong. I don't do nuclear medicine. So like what I said from neuroblastoma versus Wilms is usually a more calcified lesion, and I think on ultrasound you can see areas of calcification. These bright bits here, okay, I think these are all calcification. We don't see that on the MR sequences, probably because we haven't gotten the slice through it. And not really on the CT, or maybe there's a little bit, just spots of calcification, or there could be a bit of rib that has kind of gone through the ribs as well. MIBG, I just see an avidly high uptake lesion within the right paraspinal region. So adrenals, often it's the most commonly affected place, so 35 to 48%, more than your extra-adrenal retroperitoneum, then followed by posterior mediastinum, or sometimes you can have metastatic disease, so having more than one site. Neuroblastoma, unlike the Wilms tumor, they often just engulfs rather than displace. you can get metastases quite commonly to the bone. So when you do MR, you just want to make sure you look at the bone, looking for any high stir lesions. You can also go to node, liver, and soft tissue, and MIBGs for staging, and also for follow-up imaging following treatment. You've got the differentials will include the other spectrum. So your neuroblastoma is really your most aggressive form of lesion of the nervous system. And then on the other hand, you've got the ganglioneuroma, which is more low grade and well differentiated, and then kind of a middle grade is your ganglioneuroblastoma. Okay, so if it was an isolated lesion and not so aggressive, you can put these other differentials in. And as we said earlier, the other differential would be Wilms tumor, but then you can often look for that claw sign. So staging for neuroblastoma, it's done by the International Neuroblastoma Risk Group Staging System. It was for you to stage pre-operatively. Okay, so you've got stage 1 disease, which localized tumors confined to a body cavity without any what they call image-defined risk factors. I'll tell you what they are. And you've got stage 2, which is local regional with imaging-defined risk factors. And then you've got a stage M, which is got with distant metastases. And then you've got in kids, in this child, 7 days old, and also less than a year, you've got stage MS, which is primary tumor with the metastases. Okay, so you've got, so if it's a low risk, so you stage it, and often it's managed conservatively. You do chemotherapy only if it becomes symptomatic. Which then it can either fully regress or it becomes something more low grade like the ganglioneuroma. And like what I said earlier, you do is what you follow up is with imaging. And on this MR here, you just see one that's have more extensive disease, and you see on MIBG there's also metastases higher up. Okay, and on both sides, and partly in nodes as well. Okay. Toby, do you want to add anything to this? Because I think this was your case as well.
No, it was
okay.
Right.
Cool.
I'm just going to say that the stage MS is quite important to know for exams, because they might ask you, do these patients need any treatment and things like that. So it's just to know that they're often, if they're under 18 months, even if it looks quite high grade, they're managed conservatively.
Okay, it's an important point. Just remember that. We'll come back to that when you do a bit of summary. Okay, next case.
Yeah, I've been provided with a frontal chest radiograph of a skeletally immature patient. I would like to go systematically through the radiograph. I would like to see the review areas. Bilateral epiphyses appear unremarkable. Bilateral hyla appear unremarkable. There is evidence of a ill-defined opacity overlying the right hemidiaphragm and overlying the right liver. I think I could see a few calcific foci within. Yeah, apart from this,
okay.
There is no pneumothorax, there is no pleural effusion. I think the visualized bones show no focal lesions or any fractures. So my main finding is the ill-defined opacity with calcification overlying the right hemidiaphragm and the liver. So I would like to do cross-sectional imaging for further evaluation.
Okay, so before that, we did ultrasound was done instead, and then I'll give you cross-sectional imaging after.
The serial axial sections of the ultrasound showing evidence of a heteroechoic lesion with calcifications and posterechoic shadowing on the right side, posterior to the liver. Posterior to the liver.
Yeah.
I think in the last image, the lesion is showing extension into a vessel. I could not make it. It is a vessel extension into a vessel or something.
Okay, and then I've got one more, which is a cross-sectional imaging, actually 2 more.
These are contrast and CT axial sections showing evidence of heterogeneous enhancing lesion with multiple calcific foci extending across the midline, and they are situated anterior to the kidney and separate from the liver. So I would like to place the lesion in the epicenter in the adrenal gland. So I would like to know further history of the patient, like what are the clinical features of the patient.
Just before that, I've got one more.
Yeah. These are the axial MRI T2 showing heterogeneous lesion with T2 and T2 hyper and hyperintensity. At contrast eminence, there is no significant enhancement. I think the ADC images also do not show significant ADC reversal. Yeah, so I would keep the lesion within the adrenal gland on the right side, which is crossing the midline. Can I know the clinical history?
So if I'm not wrong, I think again this was Toby's case, but in generally the clinical history will be palpable liver age. You do an ultrasound to find out why query hepatomegaly.
But the lesion is seen separate from the liver, posterior to the liver.
I think it's
different.
I just think it's on the sections we're providing. If you look at the lateral aspect of the lesion on the MR, you can see that you can't see where the liver continues. So, for example, on the post-contrast, so maybe it's just the sections we're providing, but the lesion arises from the liver.
Okay, then I would like to retract my statement and will keep the lesion, the epicenter of the lesion within the liver. So when the lesion is arising from the liver, so heterogeneous enhancing lesion in the liver, my differential diagnosis will include hepatoblastoma and only mesenchymal hematoma. So I would like to do tumor marker imaging like AFP to correlate with the lesion. I would like to compare with previous imaging, inform the referent clinician, and do pediatric oncology MDT for further evaluation.
Okay, so yes, I think the case, again, we haven't shown you all sequences, but I think this is just it's just real life case to show that if a tumor is very large, it can be sometimes quite hard to place where it is. So which is why it's important to just keep a close eye on where you can see the margins of the tumor, which starts and ends. It's not coming from kidney sake because you can see a nice fat clean around it. You can be misled because of the calcifications. You think it's neuroblastoma, but it was on multiple serious imaging that it was thought that it was rising from the liver, so hence hepatoblastoma in this case. Okay, so you've got different types, epithelial, mixed types. Often hepatoblastomas, you can have a very high elevated AFP, and 60% of them happen less than 2 years old. And again, with all the other tumors, you're thinking of the associated syndromes such as Beck-Witherman, hemihypertrophy. Hepatoblastomas most often happen in the right side of the lobe. You can rapidly enlarge, rupture, or hemorrhage. And important thing here is that in the oncological centers, they often do what we call a pre-text staging. You use the pre-text score for staging and risk stratification. And what you look is where the tumors involve, how many segments, the number of segments. And the other things of the imaging defined risk factors would be is the caudate lobe involved, whether can they separate things away, so to preserve part of the liver or for do you need a whole liver transplant, any extra hepatic disease, any rupture, looking for metastases, is your portal vein involved, is your hepatic or IBC involved. So the higher the score, with the increasing number of image-defined risk factors, with a very high or very low AFP puts in a high-risk category. Okay, so
Sam, I'm just going to step in again with this and just say that so on the ultrasound, and you can see it on the CT and on the MR as well, you can see portal vein involvement with tumor thrombus. So you can see there that's thrombus within the portal vein on ultrasound. It's the right portal vein because I actually did this ultrasound, and any thrombus within the portal vein is within the vascular structure with hepatoblastoma is defined as tumor thrombus. So it's an imaging defined risk factor. So you can't just say it's thrombus because of compression or something by the mass. It's defined as tumor thrombus and invasion in hepatoblastomas. So it's really important that you assess the vessels if you are reviewing the case for an exam or even just clinically reporting one.
Okay, thank you for that. So things to think about, HCC, but often this happens a lot older, more than 10 years old, and you would think of there's something else that's underlying, whether it's a biliary atresia, is it hepatitis, is it NT1, alpha-1 antitrypsin deficiency, hemochromatosis, glycogen storage diseases. And then I think you mentioned a mesenchymal hematoma, which is good differentials. However, this is usually 2 years old. I think this was quite a young child as well. But often in the mesenchymal hematomas, you get something that's a bit more multicystic, mixed solid cystic. Well, this one is quite solid. Things to think of. Another thing that could look like this would be, I know I wrote undifferentiated embryonal sarcoma, but a true case was when we thought one was hepatoblastoma. It was sent away and they thought it was a hemangioma. It's because hemangiomas can also look quite aggressive, but often when you do phased imaging with contrast, you can see that peripheral enhancement with central areas of persistent non-enhancement, and of course, and sometimes you can also get heart failure with shunting. Okay, so that's something to think about as well. Okay, next case. 2 images. So this is ultrasound first, and then I'll show you the next one. Okay, so have a look at the ultrasound.
Yeah.
And then I'll show you the MR. Okay, and I'll go back to the ultrasound. Just let me know if you want to stay at ultrasound or MR.
Yeah, I'll complete the ultrasound. Yeah, first. So these are the serial transverse axial section images showing evidence of diffuse bowel wall thickening because I could see the air pockets within the lesion, diffuse bowel wall thickening, multiple hypoechoic lesions, and few lesions are showing central necrosis, and these lesions are noted in the right midline. And can I go to the MR images?
Yeah.
These are the coronal T2 weighted and axial T2 weighted images showing evidence of a thickened bowel loop, like showing aneurysmal dilatation, thickened bowel loop. And or either it can be any heterogeneous lesion with the central necrosis. So my differential diagnosis here, there is minimal free fluid in the pelvis. I think the visualized liver does not show any focal lesions. The visualized bone show any altered signal intensity. My differential diagnosis here will be in lymphoma because I'm thinking of aneurysmal dilatation. However, there is no significant. Yeah, there are few enlarged lymph nodes with aneurysmal dilatation. Differential diagnosis will be lymphoma. Can I know the age of the patient?
Patient 7.
Do we have any other images, or these are the only images?
No other images.
So I'm thinking of aneurysmal dilatation with multiple conglomerate lymph nodes, likely lymphoma. The other less likely differential will be a GIST with central necrosis.
Yeah, so often these ones a lot easier when you are scanning. So this is a patient that I scanned, and when I looked at it, I thought there was exactly what you thought, aneurysmal dilatation, and you could see that there was passage of bowel contents through here, which you can't really capture very well on still images. With all these notes, the presenting complaint was whether he had appendicitis because he had abdominal pain, and this turned out to be small bowel lymphoma, and I thought it was nice. It doesn't change from what I've mentioned earlier, in the previous head and neck lymphoma, but I just thought it was a nice picture to include of small bowel lymphoma, okay, with aneurysmal dilatation. And the main things that you think of GI cancers, are you thinking more of adenocarcinoma? But often this happens a bit in adults unless they've got underlying polyposis or underlying syndromes, and these ones are usually more focal wall thickening with luminal narrowing and obstruction. And this kid didn't present with signs of bowel obstruction. Okay. Next case.
Yeah. Can you know the age of the patient?
Patient is 1 year old,
Okay.
and what they thought was a palpable mass in the pelvis.
Okay. So I've been provided with serial axial sections of the ultrasound of a 1 year old child showing evidence of, I think the first section within the bladder, there's evidence of a polypoidal hyperechoic mass noted, and there is dilatation. I think there is hydroator necrosis of the right kidney. We see in the third and the fourth images with dilated pelvis, and And the left ureter in the lower sections showing evidence of a polypoidal mass and the thickened bladder wall. And the left kidney is also showing the hydroureter necrosis with dilated pelvis and cortical thinning. So the epicenter of the lesion is within the urinary bladder polypoidal mass, which is causing bilateral renal obstruction, causing upstream hydroureter necrosis. Are there any other images?
There are other images, but you can have a look.
These are the contrast and CT images showing evidence of dilated pelvic calcium system and ureter on the left side and also on the right side.
Okay, I've got another one.
And the previous findings that are seen on ultrasound, there is a heterogeneously enhancing polypoidal mass lesion within the urinary bladder causing upstream hydroureter necrosis. I think the age of the patient is 7-year-old. Yes, right?
No, 1 year old.
1 year. So my differential diagnosis will be, I think, have they done any Doppler, color Doppler over the bladder? Can I go to the ultrasound?
Yeah. So I think I did I did ultrasound. There's just minimal vascularity, but internal vascularity.
My differential diagnosis here will be any rhabdomyosarcoma of the urinary bladder, less likely to be clots or any hematoma within the bladder to cause such bilateral hydroureter nephrosis. Less likely to be transitional cell cancer, which is more likely seen in the adults. So I would like to inform the referring clinician and do a pediatric urology or a cystoscopic evaluation and biopsy of the mass for further characterization. Do staging. Okay.
So it's good. I put these cases in just because I thought it was quite classic. It was embryonal rhabdomyosarcoma of the bladder, and you have this characteristic cluster of grapes look. And of the subtype, this is botryoid subtype, and often in looking at these like grape-like clusters. I thought it was quite nice to just see because I mean, before starting pediatric radiology, I actually haven't seen one of this, so I thought it was quite a nice thing to see if it was like an Aunt Minnie. Other things to think about, yolk sac tumor, but then it's more ovarian pathology. You see it in the abdomen, pelvic rather than within the bladder, pelvic neuroblastoma. Again, usually external, not within the bladder unless it infiltrates. And so also for your sacrococcus teratoma. Okay. I'll just show you cases because these are ones that it's just classic again. So similar example, or rather similar diagnosis, but different case. Okay. Seeing how it looks like on MR. Okay. With evidence of restricted diffusion. Okay. Next case.
I've been provided with serial axial CT sections showing evidence of a heterogeneously enhancing lesion in the right iliac fossa and the intraperitoneal region. There will be a few areas of necrosis within. And the lesion is seen to displace the adjacent bowel loops. May I know the age and gender, age of the patient?
Yeah, so it's a 15-year-old girl with increasing abdominal distension.
Yeah. These are heterogeneously enhancing abdominal pelvic lesions extending from the pelvis into the abdomen. Do you have any other sections of these are the only images?
No, this is it.
So heterogeneously enhancing lesions in the pelvis and the abdomen involved in both bilateral iliac fossa. I think the epicenter of the lesion would be involving bilateral adnexus or ovaries. So I would like to do a tumor marker correlation like AFP, beta, HCG, and I would like to compare with previous imaging, inform the referring clinician and pediatric gynecology or pediatric oncology MDT for further management of the lesion and do CT chest if there are any metastasis.
Good.
So
okay. So yeah.
Thinking of yolk sac, any germ cell tumors.
Yeah. Good. So this is a yolk sac tumor, okay, and I think the next cases I'm going to show you is just various ovarian malignancies, just because I'm conscious of time, And the reason why we're showing you this is that it's just you need to have some form of different shows when you face the exam, because there are only a few things are quite classic that you can say this is definitely it. If not a lot of it, you do need biochemical markers and to correlate. So York-sac tumors, this is a 15-year-old, but they commonly occur in the second and third decade, so kind of same time, and it was in this lady had classic, so it was a very short duration of symptoms. She just basically had increasing abdominal distension. They are quite heterogeneous, solid cystic masses, and often they have associated elevated AFP. And so other things to think about, you can think of dysgerminoma, similar to what we call a testicular seminoma, and 5%. So your LDH is one of the raised LDH, the thing they think of, because about only 5% of them only secrete beta HCG, unlike choriocarcinoma, where your key marker is your beta HCG, and so is your embryonal carcinoma. Okay, is there anything else I need to tell you about it? Not really. So yeah, so it's just more of having being able to say this is likely a pelvic malignancy, give some reasonable differentials, and talk about your serum markers. Okay. So next one.
Yeah, I've been provided with the T2MR axial section and ultrasound of the pelvis, showing evidence of a T2 ill-defined T2 hyperintense lesion, which is involving the left ovary, because I could see the follicles in the right ovary separately. I could not visualize the left ovary here. And the lesion in the ultrasound, it is showing hyperechoic foci and also a cystic component. May I know the clinical presentation and any other imaging of the patient?
Nope, that's it. That's it.
I didn't get it.
Hello.
Hello?
Yeah.
Yeah, can I know the history of the patient and any other clinical, any other images?
So no other images. This is a 10-year-old girl with incidental finding.
Yes,
She had
so I'm thinking in terms of a dermoid because of the hyperechogenicity and there's like a mature teratoma. I would like to do any fat suppression imaging to further characterize the lesion.
Yeah, so this is one of the things that you probably would come out exam, because it did come up for me in my 2B exams. And the reason why I've shown this is that on the MRI, you can see there are also areas of blooming artifact. Yes, you can on T2, you are thinking, is this your blood products or is this calcification? So on ultrasound, you can see that there's some shadowing here. Okay, it's hard to tell because again, it's static, but that's calcification within it, and some bright areas which could represent fat. It's involving the left ovary, because the right ovary is well seen, which is here. So this is a mature cystic teratoma or a dermoid tumor, and often we know it contains a mixture of fat, hair, calcium, cystic products. And on ultrasound, the things that we look for, which I'll show you in the next slide. So a dermoid plug or an echogenic nodule, protruding the cyst. We don't have it here, but the dermoid mesh, so linear echogenic foci of hair. You've got that tip of iceberg sign, which often often when you have got large calcified components within it. And on radiographs, what you're looking for is a tooth-like calcified body. Of course, if you see something more round in that region, you can think that it could be a pendicolith if they've got pain. And MR fat suppressed sequences help you to confirm the presence of fat within it. And of course, your complications, anything with a large ovarian mass would predispose to torsion, can rupture as well. And this thing I did not know, anti-NDMA receptor encephalitis. Okay, I don't think the exam is going to give you that they've got encephalitis, but it's quite a cool thing if you were reporting in your pile, you saw this, and they said they had encephalitis, they could help you to say this is most likely to represent a dermoid. So like what I mentioned earlier, so you've got other neoplasms that this could be differentials of, perforated appendicitis if you're just given a plain film, and patients at risk of ovarian torsion. Just remember, the teratoma is one of the most common ovarian neoplasms under the age of 20, so in young girls, in young ladies. So instead, from StatDX, this is the derm on ultrasound. This is a dermoid plug or Rokitansky nodule. This is the dermoid mesh. These are hair products, fine linear echogenic. And this is a tip of the iceberg sign. So you've got this shadowing, which obscures the rest of the lesion. And these are some echogenic signs in there here. And so you see here the tip of the iceberg sign. Okay. Just going on a bit more, just because this did come up for me in the exams, I said earlier, and it shows you that there's some tooth-like calcification within there. And on ultrasound, on MRI, it shows you nicely an ovarian lesion with foci of calcification. CT actually, apologies, CT showing you calcified with low density, so probably a mixed solid cystic lesion in there, or probably even areas of fatty components where the areas are more hypodense. Okay. So next case is just to show you small cell carcinoma ovary. Looks very similar to the yolk tumor. You can't really tell, and that's how it looked like on MR. And the reason why we knew about it is because it was resected and studied under histology. The thing why I wanted to raise your attention is to show you how ovarian torsion looks like on imaging. So, and I think this shows it quite nicely. So I'm just scrolling it down, okay. And I'm going to scroll up again. So I think what I wanted to hone in is to, if you can have a look at the nature of the ovarian vessels and also at the position of the uterus, okay. So the uterus is pulled to the side of the torsion, is retracted to the right. And at the same time, there's also very congested ovarian vessels here. So, which is associated with the mass. So this was a right-sided one. So you've got, and you can't often see the twisting, but with the evidence of a congested vascular pedicle and ovarian vascular pedicle, as I'm going down now, and in combination with the fact that you've got this uterus that's pulled to one side, the side of the congested pedicle, you can, on cross-sectional imaging, these are signs of ovarian torsion. We often mention about it on ultrasound, but we don't really see it often on, or rather, we don't really look for it on cross-sectional imaging. I thought this case nicely shows that. Okay, so congested pedicle, uterus pulled to the side. Think of ovarian torsion. So apologies, I've only just given you a general radiologist view, a general pediatric view of some tumors. So midlines, we looked at the craniopharyngioma, the germ cell tumor. You think of, so just remember the pineal calcifications, the pineoblastoma versus your, so which is quite peripheral nodular, versus your pineocytoma, which is the exploded one, and then the pineal germ cell one, which is central, it engulfs it. You've got your DNETs, your different is a cortical based epileptogenic tumor. The differentials be a ganglioglioma, and your infratentorial tumor, so your medulloblastoma, your ependymoma, which is more plastic, so it extrudes through all the different foramen, and then your diffuse midline glioma, which is often centered in your brainstem in a pediatric setting. Head and neck, think of your lymphoma and rhabdomyosarcoma. You have to always, I mean, I would, in my opinion, I would say if you've got a head and neck lesion, always put in rhabdomyosarcoma as that, then lymphoma, and then you can put in all the other differentials, okay? Liver, think about the claw sign to help you differentiate where is it coming from. You've got your hepatoblastoma, adrenals, your neuroblastoma. Think about this. Remember the staging of MS in the infants less than 12 months, so less than 1 year. Your kidneys, you've got Wilms, congenital mesoblastic nephroma, and then your RCC, so depending on age, so RCC, the older population, Wilms, the younger population, GI, your small bowel lymphoma, your ovaries, so think about your cystic teratoma, because that's one that's quite nice to see on all modalities, and all the other more obscure, or rather, tumors that I don't often see. Bladder, your rhabdomyosarcoma, which is your the bunch of grapes of